This Week in Richmond is made possible in part by Dignity Memorial, caring for our communities with a network of funeral homes and cemeteries in Virginia and throughout North America. More information about Dignity Memorial's providers is online at dignitymemorial.com. The Virginia Chamber of Commerce, the voice of the Virginia business community, working in legislative, regulatory, and political arenas to promote the free enterprise system. Information at vhchamber.com. Virginia hospitals and health systems provide jobs. They support our economy and promote public health. Local hospitals are always open to help people with unexpected health needs. Having a stable healthcare network is vital. Virginia hospitals are our lifeline.
It's amazing what my students with special needs can accomplish. Their pride is priceless. That's why I teach.
Brought to you by the Virginia Education Association, because a good education is good for everybody.
Additional support is provided by these sponsors. And by the members of Virginia's public television stations. Thank you.
Welcome to This Week in Richmond, and a very special welcome to two great guests. We've got a fantastic program that's going to help bring people up to date around the Commonwealth on an extremely important issue. Joseph Trapani, Chief Executive Officer and Managing Director, I believe is the title, yes, at Poplar Springs Hospital, and Jennifer Wicker, known for a long time, but now in a role with Virginia Hospital and Healthcare Association as the Intergovernmental Affairs Director of that area. So appreciate you all being on. There was a news conference not too long ago that caught our attention. It was being held on behavioral health issues that really are being pushed and promoted by the Hospital and Healthcare Association, by the General Assembly members, and that's what we really want to bring people up to date on. Many of them are aware that the Deeds Commission has been going on for some time. There's efforts to look at some reforms. For people who didn't see the news conference, didn't know about that, haven't read that much about it, let's tell them about it, and either one of you start.
I'm happy to take a stab at it. So, well, first of all, David, thank you so much for having us here.
Delighted.
It's an honor to be a part of this program. As you mentioned, yes, the Hospital Association announced a pretty innovative legislative package on last week around behavioral health. I've been in my role for a little bit over a year and a half with the association, and one thing that was clear was that our members wanted to take a more active role in addressing some of the concerns that they see as they treat patients throughout the Commonwealth. And so our legislative package is focused on three legislative items and one budget item. And it's really focused around the emergency crisis process that a lot of individuals deal with when they go into the emergency department. And as you indicated, behavioral health has been a huge issue throughout the Commonwealth, throughout the nation. With the opiate epidemic,
yes,
and the substance use disorder that a lot of people are facing with, it's really real to a lot of people, and our legislators, our governor as well, and the Hospital Association hope that we can take some steps in trying to address some issues. Don't know how much in detail you want me to go into the legislative package right now, but like I said, we have three various items that deal with the emergency psychiatric evaluation process. Right now, community service boards, workers are the only individuals that can do an emergency evaluation to have a person temporarily detained in order to determine whether or not they should be committed. And we want to change that. We want, in a situation where a CSB worker can't arrive for whatever reason, can't arrive to a hospital within a 2-hour time frame, we want to have an alternative behavioral health professional be able to do the evaluation and to get patients through the process and get them to the treatment that were needed. So that's one of the items that we have.
Hold that one just for a minute, because
Sure.
probably many people don't realize that there are only, under current arrangements, there are only certain people that can do that initial screening.
That's right.
And many people are aware at times of waiting time in emergency rooms, but may not be aware that on a mental health issue that the wait is not so much because the staff in the hospital can't get you in, but they're waiting for someone else to arrive. So,
Right.
so you're hoping to get that changed. So if it's more than 2 hours, then someone on the hospital staff could do it. Is this a?
That's correct. So every hospital, as we know, have qualified professionals amongst their staff who can, with the appropriate tools, identify
Right.
the admission criteria for an individual into an inpatient psychiatric hospital bed. Currently, the system requires that an individual displaying signs would have to be assessed by a licensed mental health professional through the Community Service Board, which are distributed throughout the Commonwealth.
Right. But it's a greater distance in some, and even when it's close proximity, you can get caught up on the highways.
And the resources vary
Yeah.
in different localities as well. So as a hospital operator, I feel that this legislation proposal benefits the patient such that if they are in a hospital and they are requiring care, we have the individuals who can immediately make that assessment to determine whether or not they need to be admitted, not to forego the process that's already in place, but to support the process that's already in place, because we have seen an increase in the demand for mental health services just based on volume over the past 2 to 3 years. And I think every Virginian is very familiar, either through larger scale incidents that have taken place in the Commonwealth, or just in the fact that every family at this point is impacted by mental illness in one way or another. I think that is one way this package promotes access, among others, which I'm sure we'll get
So
into.
is that the one that's called pre-admission screening?
That's right.
The
Correct.
one? So,
And if I may add
Yes,
add a personal
please.
note to this, personally, behavioral health is extremely important to me. I actually have a mother who is bipolar, and as I sit here right now, she's actually in a hospital getting care. She's in Syracuse, New York, but still, as a family member, it's a very traumatic time, and if you're in the emergency department, waiting for a significant amount of time for your family member to get evaluated to determine whether or not they meet criteria for further treatment, it's very stressful, and we want to make sure that patients are being evaluated in a timely fashion. And this in no way is a knock on the wonderful work that the Community Service Board workers do. We are looking to partner. We are looking to be, a support, and when they're not able to get out to the hospital within that 2-hour period, we want to be there to partner with them, and we're hoping that it will be received in the way in which we intend, to get people services that they need, to get them the treatment that they need in a timely and efficient manner.
so if this goes forward, okay, let's say I'm the CSB
Sure.
in charge in your hospital, and I get contacted, would it give me the ability to say, I don't see how we can get there that quickly. So it's not like putting a timer on and waiting 120 minutes and then be able to do it. It would permit the CSB to say, we don't have someone who can get there in 2 hours. And so then you could move on even more rapidly.
Ideally, what you would like to see in each locality is the hospital partnering with their
Yes.
local CSB,
Yes.
in that we would communicate real time what's best for that patient. And if
Right.
that CSB worker or that CSB knew that they were unable to provide that service within the 2 hours, hopefully as a hospital we would be able to do it in a much quicker fashion.
Or the call might be from me, the CSB. I know that person very well. We've seen them any number of times. if you give us an hour and a half or so, we'll be there.
That's right,
And so
exactly.
that would work. You'd have someone coming in who maybe has really provided services to that person on outpatient basis. Okay, so now that's only one of
One of-
three legislative initiatives,
That's
and
right.
then there's a budget. So what's another one of the?
So the other legislative item that we have is around the psychiatric bed registry. As you may remember, the psychiatric bed registry came out of the 2014 General Assembly session, and the purpose of the psychiatric bed registry is to identify available inpatient psychiatric beds for individuals that are in need. And in a perfect world, that system would work seamlessly. Unfortunately, we're discovering that a lot of calls are still being made to hospitals manually versus using the psych bed registry to say, you know, I need a bed and these hospitals have beds available, and making that quick connection. I've been told that CSBs are having to make upwards of 20 or 25 different phone calls to various hospitals to find an available bed. So the way that we call it, we've changed it a little bit now. Instead of the patient matrix, we're calling it the patient registry now. And the way that the patient registry would work is any individual who's looking for a bed would be able to put de-identified information into this registry. So we're talking about the gender of the individual, the type of disorder that they may have, and any other medical things that need to be taken into consideration. That information is put into a registry. An alert is then sent out to hospitals, the same hospitals that are part of the psychiatric bed registry. And if a hospital has available beds, then they are able to reach out to the contact, say it's the CSB, and say, hey, we have a bed available that meets the criteria that you're looking for. Let's have further conversations about the needs of the patient to see if we can initiate an admission. And, you know, and the hope is that in conjunction with the psych bed registry, we will cut down on the amount of time that it's taking to find patients the beds that they need. And when there are hospitals that have beds that are available, instead of being that 30th call, you know, they can actually reach out and initiate an admission.
I think to provide some perspective in terms of Poplar Springs Hospital just in itself,
Right.
we operate 128 inpatient psychiatric beds. 91 of those are for adults, 37 currently for adolescents. In the previous year, we've treated close to 3,500 patients. So in the sense of an operating system for a
Right.
bed board, that's a lot of work that goes into making sure that every admission and every discharge is being updated. So to have that be real-time, accurate information to the CSBs is a challenge. I think what this does is it affords us the opportunity to balance that by going in and saying, we may not have had the opportunity to update that psychiatric bed registry, but we are responsible to our beds and our capacity. We know we can take that patient. Let's call on that patient and see if we are appropriate service or can provide the appropriate care for that individual. Again, I think it just expedites access for the patient to get the care at the level of care that they need, which is another reason why we're highly supportive of this.
I know you've been in conversation with legislators and been following the studies. On these first two, do you have chief patrons or ones that are taking the lead that we can let the public know about? Who's doing the one you just talked about on the patient registry?
For the patient registry, we are honored to have Delegate Joseph Yost.
Okay.
And as
All
I'm
right.
saying this, I'm making sure that I'm not getting the names confused.
Right, yes.
Because actually I lied. It's not Delegate Joseph Yost. It's Delegate Roxanne Robinson.
Okay.
So I apologize,
Yeah.
Delegate Roxanne Robinson for the patient registry,
Mm-hmm.
and Senator George Barker for the patient registry. So we're doing it on both sides of the chamber. And for the emergency evaluation legislation, Senator Ben Chafin has agreed to sponsor that for us.
Okay, so What about the third one then? Is that the one that Yost is involved?
That is the one that Yost is involved in.
So he's going to be the patron of the one. So tell us about the third
So,
initiative.
yeah, sure. So the third initiative, it's the 24-hour stabilization period. And this has to do with the time frame in which a person has already gone through the evaluations. They've determined that they do meet commitment criteria, and so they're being held temporarily to receive treatment. So they're under the temporary detention order, or TDO. Current code says that a person has to have a commitment hearing no later than 72 hours. So you have a maximum of 72 hours that a person could be under a TDO before they have to have their commitment hearing. We don't have a minimum. So some of our hospitals are experiencing situations in which a patient may come to their floor in the middle of the night, so say 2 or 3 o'clock in the morning, and it is possible that a commitment hearing for that individual may be heard, at 10 o'clock that same morning. So, imagine a person who's going through a psychiatric crisis, who really has not had a chance to receive treatment and to stabilize, or to even be seen by the treating physician, the psychiatrist that would be rounding on that unit. And that person then has to go in front of a special justice to determine whether or not they should be committed, whether it's involuntary or voluntary, or discharged. We want to ensure that individuals are in the best place that they can be before they have a decision made on their commitment. And so the goal is to allow 24 hours to elapse before the individual goes to have that hearing before a special justice. And the hope is that they will be treated and stabilized enough to be able to have a hearing, and the best decision can be made for their further treatment.
From the provider perspective, I think what that does is it ensures that our physicians, our nursing staff, and our clinicians all have the time and opportunity to complete an accurate and full assessment of every patient before they then are on the docket for their hearing, so that our independent evaluator can also make a very clear argument for that patient in their hearing. So I think on both ends, for the patient to present their best selves, but then for us to have that, all of our assessments take place within a 24-hour period, so that time period just lends itself to a better picture of that patient, why they were admitted, and how we feel their course of treatment will continue in the hospital.
So when you decided to make this initiative and got a delegate who's going to be introducing it,
And a senator, Senator
Janet
Janet Howell will be
so
introducing
you
on
got
the
one
Senate side.
each chamber there
Yes,
too.
yes.
Is it because a certain number of them, as you've gathered the data, are being, I don't want to say rushed, but they're happening in less than 24 hours without adequate time? I mean, it's not, so it's a real problem that you're addressing.
Right, right. All of these proposals that we're putting forth have come directly from our members who are in the trenches doing this work day to day. And so, yes, with everything, everyone is not experiencing the same type of, type of issues, but there was a significant enough number of members who are dealing with this issue that we felt it was important enough to bring to the forefront. And interestingly enough, the University of Virginia, the Institute of Law, Public Policy, and Psychiatry, they actually did a report several years ago, and what they found is that when you allow that 24 hours to elapse, more likely you'll have patients who voluntarily commit. And when they voluntarily commit, that actually helps with their treatment. They're vested,
Absolutely.
they want to be
Yes.
there, they're part of it. And that also lends to the fact that you will have less days that they're required to be in the hospital for treatment. So the positives are, you get people who are vested in their treatment, and their length of stay in the hospital will not necessarily be as long. But one piece of feedback that we have received is that there are people that are concerned about the individual who may not need to be there for that full 24 hours. Say that individual gets better or something like that, and they really are ready for discharge. There was concern about mandating individuals to be in the hospital for 24 hours. And there's actually something in the code currently that speaks to that. And the treating physician has the authority, if they deem necessary, to discharge the person at any point during the TDO process. We would not change that, and we would not want to take away the ability for the provider to make the decision that the person should be discharged earlier.
And Jennifer, you brought up a really good point in speaking about a patient's investment in their treatment. When a patient self-commits or is invested in their care, either involuntary or voluntary, what you see is at the end of their course of treatment, that investment continues. They follow up with their outpatient providers. They follow up with the next level of care. And that continues to promote reduction in readmissions, which is a large focus. And we want to make sure that as we solidify a discharge plan with the patient's investment and their feedback, that they're following up post-discharge and not having to use that level of service as frequently.
So a budget issue,
Yes.
and a tight budget issue
Well,
year. Yeah.
so actually, we have come to the conclusion that it's a budget amendment that will request a study of the LIPOS program, which is, and Joey, help me in case I get it wrong, but it's a local inpatient purchase of services.
Correct.
And that is money that is appropriated to DBHDS, and they then give it to regional CSBs. The CSBs use that money to actually purchase inpatient beds for individuals who are uninsured. And there are a few things that we would like to have reviewed around that program to ensure that it's meeting the needs of the patients and it's increasing access. There's some concerns with money running out within 6 months. There's concerns about the fact that the money can only be utilized for patients who are admitted involuntarily. And as you can imagine, that incentivizes people to be committed that way. And again, to Joey's point earlier, you know, we really want people to be able to enter the system voluntarily. And it should not matter whether, you know, their commitment disposition should not matter. What should matter is where they are clinically and do they meet do they have a need? And if they have a need, we should be supporting that. So the study would look at LIPOS and look at the way the program is working and see if there's other ways that money could be utilized, like in transportation, for example.
So let's say in the closing minute or two that I'm a legislative staffer. I won't say I'm a legislator. And I haven't been following this issue as closely as many of my colleagues have. The question then is, have you come up with these on your own, or are these things that are happening in neighboring states? Are these some of the best practices, or would some of these be just cutting-edge, Virginia-first issues?
Well, that's a loaded question, and I'll try to quickly.
It's loaded.
It's a mixture. It's a mixture. All of the proposals are the results of conversations amongst our hospitals, and from administrators to clinicians, they've all been involved. Some of these ideas have come from other states. Some of these ideas have been a result of work groups that have already taken place in this state, but have not come to fruition. And so we're hoping that we'll be able to lend a new perspective to it and help individuals, help our legislators understand that the Hospital Association wants to be part of the solution. There are a lot of concerns around behavioral health, and we want to be part of the solution to help improve care and access for all Virginians.
Well, that's probably a good wrap-up for the show, and I thank you both very much for being on This Week in Richmond, and encourage people to focus on this issue now that the session is convening. knowing that these issues will be front and center. So thank you.
Absolutely. Thank you. Thank you.
This Week in Richmond is made possible in part by Dignity Memorial, caring for our communities with a network of funeral homes and cemeteries in Virginia and throughout North America. More information about Dignity Memorial's providers is online at dignitymemorial.com. The Virginia Chamber of Commerce, the voice of the Virginia business community. For jobs, the economy, and public health, Virginia Hospitals, our lifeline.
The Virginia Education Association, because a good education is good for everybody.
Additional support is provided by these sponsors. And by the members of Virginia's public television stations. Thank you.